So when we switched to this COVID response, we switched to an enterprise model, and that really unlocked a lot of pieces for us. And that was coming on the heels of recognizing there were a lot of challenges in the direct-to-consumer model, because even when we were selling these kits for $3 a serving and they were SNAP eligible, there was plenty of families who were saying, this is too expensive, I can't afford this. And we said, we know we need to find a way to shift this cost burden away from families who are already food insecure to somebody else who's going to also gain value from their health. We believe that not only are we getting food, not only are we addressing the social determinants of health here, but obviously if you are eating healthy food, you're going to have better health outcomes. And we said, who is going to benefit besides the community members from these health outcomes? Who's going to find value in that? Who's going to bear that risk? And the answer to that is healthcare payers and insurers and hospitals. And the way that value-based care organizations work, more or less, is in a 30-second summary. There's a relationship between insurers and hospital, and they say, we expect your population to cost this much based on who they are, what their conditions are, et cetera. And we're going to give you this much money to treat them. If it costs more, sucks, you got to pay for it. If it costs less, great, you get to keep the difference. And that's designed to incentivize hospitals and providers to not charge fee for service, which is going to encourage utilization. If I'm going to build a car and I'm going to get paid for every screw I put in, I'm going to put a lot of screws in that car. To more preventive focused, more cost-effective designs. So saying, how can we not treat people who are coming into the emergency department or manage people who have diabetic conditions, but how can we prevent people from having those instances happen, because it's much more cost-effective to do that. When you become diabetic, when you go from pre-diabetic to diabetic, you have instantaneously a 400% increase in your cost of care. So you can weigh the cost as an insurer of, paying for insulin every month versus paying for a food subscription. And so we had this model where we could now do volume. We figured out how we could do delivery. And now we started to build partnerships with first community health centers who, again, surprise, surprise, met us, found out about us because they were coming to the farmer's market and saying, wow, this is such a great solution. My patients would love this. And hospitals and ACOs. And that's really where we are in our journey right now, is we have a lot of partnerships with community health centers, but again, they don't really have tons of funding. They're doing some programs with grants and maybe they have some funding here and there, but we want them to be people who are prescribing the kits, issuing food as medicine prescriptions for our meal kits that then the insurers are covering and reimbursing. And that is how we can shift the cost burden from patients to these insurers who bear this risk, who are going to get value from their members being healthier, and still have it be connected and integrated with the community who they're going to their local CHC, their nutritionist is saying, here, I think that this would be helpful for you. It's free, try these meal kits. And where we are in that stage is effectively proving out or validating our impact and looking to demonstrate not only that we're facilitating healthy behavior change, and hey, even when folks aren't eating these meal kits, they're making better decisions about what they're eating, how they're cooking, and things like that. But we're also seeing improvements in health outcomes.
Our theory of change was always that, okay, this is a gap in terms of social, in terms of health, in terms of the lives that people aspire to and what they want to provide for their friends and families when they share meals. And so we had already started collecting the behavior change data. And now that we are, focusing still on community response, but also now with the CHCs, we're increasingly able to validate that theory of change into clinical metrics. And ultimately, when we're able to take it one step further and look at with the right populations and what their cost of care is, when you deploy these solutions, not just addressing the immediate acute needs that they have for what they're going to eat tomorrow, this evening, but also really showing them how cooking and eating is not just easier as a result of our service, but also something that they can take joy in, something that they like to share, something that they want to continue. That's the next stage. And those are the proof points that our next partner organizations want.